Now move on with our main lecture for tonight. Our next speaker will talk about one of the most deeply interesting topics for both nephrology and cardiology. Hence, I would like to acknowledge the virtual presence of some of our cardiology colleagues. So, nandyan sila. Thank you for joining us tonight. In addition to my earlier introduction, our next speaker is more than a dream weaver, but also an enabler of many young aspiring doctors. She is the newly appointed Professor Emeritus by the UP Board of Regents, a former Dean of the University of the Philippines College of Medicine, wherein she had served the college for 2 terms. She belonged to the UP College of Medicine, class 1977. So to discuss the topic on the kidneys and failing heart, please help me in welcoming Dr. Agnes D. Mejia. Take it away, ma'am.
This is okay. Okay, before I start, I'd like to give my very best wishes to the new Board of Trustees headed by Beth Montemayor, and congratulations to the old Board of Trustees headed by Beth Ruasa. I would like to thank the Scientific Committee headed by Russell Villanueva for this wonderful webinar series. This is my second webinar lecture in my life, and I'm quite uneasy about it. So I decided to be here in the PSN office to be assisted by Rhea and CJ. So let's roll. I have no disclosure. It is estimated that 38 million people worldwide have heart failure, with most published studies reporting a prevalence of between 1 and 2% of the adult population. Data from Europe and North America suggests that 1 to 2% of all hospital admissions are related to heart failure, amounting to more than 1 million admissions annually, with 80 to 90% being due to decompensated chronic heart failure. The syndrome still carries a poor prognosis. 5 to 10% die during hospitalizations, with a further 15% dying by 3 months, and over half die within 5 years from their first hospitalization. Rates of rehospitalization are also high. While most of the population-based data come from North America and Europe, there's a huge gap in knowledge in the Asian region. Asia is currently home to 4.4 billion people, comprising 60% of the world's population. This paper, published in the International Journal of Cardiology in 2016, with the lead author from the Philippines, Dr. Eugene Reyes, aimed to investigate the current state of heart failure in Asia and to foster implementation of measures intended to improve the standard of care in the region. This study is made up of 9 countries: Vietnam, South Korea, Taiwan, Hong Kong, Philippines, Indonesia, Singapore, Malaysia, and Thailand. In terms of population, the smallest is Singapore with 5.7 million, with a life expectancy of 84.4 years and mean age of 34. The most populated is Indonesia with 255.8 million, with a life expectancy of 72 and a mean age of 29.6. The Philippines, based on the 2016 data, we have 101.8 million people, life expectancy of 72.5, and a very young mean age, 23.2. Singapore has the highest growth per capita or GDP at 58,910 US dollars and 3.8% annual growth rate. The poorest so far in this data is Vietnam with 2,230,000 US dollars and an annual growth rate of 6.6%. The Philippines has a GDP of 3,260 US dollars and an annual growth rate of 6.3%. South Korea spends most, 102.6 billion US dollars are spent on health, and 6.7% of their GDP is allotted to health. In the Philippines, 13.8 billion US dollars is allotted for health expenditure, and 4.2% of the GDP is allotted to health. In this study, the prevalence of heart failure is shown here. In the Philippines, it's 1 to 2%. Highest is Taiwan. Mostly males compared to females, with a mean age at admission for the Philippines of 60, which is about the same as the rest, with Vietnam being the youngest. Cardiovascular risk factors for the Philippines: ischemic heart disease is most common, and it's most common in most except in Hong Kong, where hypertensive heart disease is the most common. In the Philippines, you have ischemic, valvular, cardiomyopathy, hypertensive heart diseases, and other causes. The underlying causes are listed here. Prevalence of hypertension in the Philippines is 64% in this population, but look at the rate of smoking. The Philippines has the highest number of smokers at 54% compared to the rest. And for renal disease, recorded based on 5 hospitals, reported about 4%. There's incomplete data on hospitalization and mortality, but for the Philippines, heart failure makes up 9% of total hospitalization. The mortality is 7% for the inpatients and about 10% when they get discharged within 30 days upon discharge. Asia is highly heterogeneous with countries at different stages of economic development. Population-based data suggests that socioeconomically deprived persons are likely to develop heart failure at an earlier age than affluent individuals. Heart failure is predicted to be highest in the poorest countries, least equipped to deal with this onslaught. And this paper, published in the early part of this year by McDonald, looked at the regional variation of mortality in heart failure with reduced and preserved ejection fraction across Asia. These are the outcomes in the Asian Heart Failure Registry. 11 countries, 46 centers. They divided this into regions. Northeast Asia is made up of South Korea, Japan, Taiwan, Hong Kong, and China. South Asia is India, and Southeast Asia is made up of 5, Thailand, Malaysia, Philippines, Indonesia, and Singapore. 6,480 patients were included with a mean age of 61.6. 27% were females, and most had heart failure with reduced ejection fraction. Their findings. This is the overall. This is based on heart failure with reduced ejection fraction, and this is heart failure with preserved ejection fraction. And you would see that the pattern is very similar for all, showing that Southeast Asia had the highest cardiovascular, non-cardiovascular, and unknown causes of death, whether it is heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. You will see the marked split in the Kaplan-Meier survival at 1 year. The crude 1-year mortality for all is 9.6%, and you would see that the Northeast and South Asia are binded together, whereas those from Southeast Asia is much lower. And if you split them into heart failure with reduced ejection fraction and preserved ejection fraction, the 1-year survival, the 1-year crude mortality for heart failure with preserved ejection fraction is 10.6% and 5.4% for those with reduced ejection fraction. But whether it's reduced or preserved, persons from Southeast Asia do poorly compared to Northeast Asia and South Asia. What are associated with mortality? This is the hazards ratio. Preserved ejection fraction, systolic BP, you can see it there, body mass index, AF. If these patients were enrolled as inpatients, the hazard ratio goes high, and those with CKD, much higher, and those with class 3 and 4, definitely much higher. In their study, there was better survival with the use of ACE or ARB or beta blockers, but not with mineralocorticoid. And they say that diuretics had the worst outcome. So for that paper, crude 1-year all-cause mortality was 9.6% in the overall cohort. However, there was a significant regional differences in patient characteristics, treatment, and mortality. Asian patients with reduced ejection fraction had worse 1-year outcomes at 10.6% than those with preserved ejection fraction at 5.4%, despite being significantly younger. Patients from the lowest income countries presented at the youngest ages, but had the poorest outcomes. Southeast Asia had the highest rate of comorbidities, and patients from this region were almost twice as likely to die during the first year of follow-up, 13.6%, and this is covered by Indonesia with 21.4% and the Philippines, 14.3%, in comparison to patients from South Asia, 8.3%, and North Asia, 8.9%, in spite of the youngest population in Indonesia and the Philippines. Japan is the most elderly country, but it only has 4.4%. Cause of death for reduced ejection fraction is 54% known cardiovascular death, 34% with assumed, and 12% unknown. Cause of death for preserved ejection fraction is very similar, 50% cardiovascular, 25% non-cardiovascular. Among Southeast Asians, the highest prevalence of diabetes, stroke, hypertension, CKD, CAD, despite their low mean age. This is not associated with inpatient enrollment. Higher risk for both reduced and preserved compared to the other two regions. Highest rate of comorbidities, lowest income, youngest population, poorest outcomes. Indonesia had the highest rate of all-cause mortality, second to Hong Kong. In our country, we have the highest BMI, Japan had the lowest, and we have the youngest cohort, 20% females, age being 55.8. But I think this is the most important message of this paper. And I quote, despite the considerable regional variations in demographics, comorbidity, and treatment, these measured factors explain less than half of the interregional variation in mortality, with unmeasured factors accounting for the bulk of the varying mortality risk. And these unmeasured factors are differences in healthcare structure, delayed presentation to healthcare facilities, access to and delivery of healthcare, and of course, the quality of healthcare. They concluded that the region is more important than demographics in predicting mortality among patients with reduced ejection fraction and preserved ejection fraction. And I'll come back to this issue later on. So tonight, managing patients with acute decompensated heart failure and renal dysfunction continues to be challenging. My purpose is to understand the interaction of the heart and the kidney, because an understanding of this interaction is pivotal in tailoring therapy of these patients. It is predicted in the United States that by 2030, the prevalence is 46%. So allow me now to tell you the story, or my story, on the kidney in the failing heart, emphasizing on acute decompensated heart failure. This is the natural history of heart failure. It may have changed. This is an old slide, but you will see in subsequent slides that this can still be true, but you can also see in the subsequent slides that maybe we can make the curve less steep. Mechanism of death is 40% sudden death, worsened 40%, and others. There is definitely progression, and I will give you the basis for that, and about 50% deaths every year. I think our aim is really not to push them quickly to that severe stage, parang ESRD. We hope we can keep them in the mild or less than moderate, but let's see if this has been possible in the past few years. These are two classifications of heart failure. The red one is in stages, and this is based on the classification established by American Heart and the American College of Cardiology, and it complements the New York Heart Association. The red stages is basically structural. It describes a patient's chronic state. It moves from left to right, whereas the New York Heart Association class describes the patient's present state, which means that you can really shift in either direction. You can go to class 4, but you have the capacity to class 3. Unlike the stages, which is basically structural, then you really move from left to right. Stage A, at risk, no structural heart disease, but as you progress leading to stage D, this is your recalcitrant refractory heart failure. They require advanced heart failure therapies or hospice or palliative care. And this is based on the Frank-Starling curve. The vertical axis is your stroke volume. The horizontal is your LVEDDP. The normal curve is the blue one. As you increase your LVEDDP, your heart pumps and throws away that blood, and your stroke volume is increased. Once you have heart failure, the capacity to contract is definitely diminished, so you end up with an increasing left ventricular end diastolic volume, pressure. The volume is increased, and the stroke volume drops, but with proper treatment, it can improve to C. Severe heart failure is your class 4, your stage D, wherein the heart cannot pump much anymore. And these patients are really prone to congestion, even B and C. But in the red one, the severe heart failure, this is really end-stage heart disease. The total blood volume is very important in heart failure. You have venous congestion and arterial underfilling. On the right side is arterial underfilling because you don't have enough stroke volume coming out. And this is characterized by a decrease in cardiac output or peripheral arterial vasoconstriction. As a result, there is now venous pooling to increase the preload, to increase the cardiac filling pressure. So the left-hand side is actually your venous congestion, while your right-hand side is your arterial underfilling. This is the picture that we would see in heart failure with respect to total blood volume. The pathophysiology and disease progression of advanced heart failure is complex and insufficiently elucidated. There is what we call a poor forward flow, which is your afterload. There is a low cardiac output resulting in unrestrained neurohumoral upregulation. And now there's a recognized backward failure where you have systemic congestion complicated by pre-existing renal dysfunction. And this is your preload. This is the concept map. You have acute decompensated heart failure, leading to reduced cardiac output, leading to decreased intravascular volume and arterial underfilling. There's a decrease in renal perfusion, and the kidney adapts by salt and water retention. This adaptation leads to maladaptive consequences. As acute decompensated heart failure progresses and the forward flow, adaptational responses occur, and these are your neurohormonal activation of your plasma renin, your aldosterone, your catecholamines, your vasopressin, and your adenosine. And they all lead to renal and systemic vasoconstriction that can further reduce the renal perfusion, that can further enhance salt and water retention. I will now show you two slides showing the evidence for this neurohormonal activation in cardiac failure. This is the role of the kidney in heart failure, relationship of cardiac index to kidney function. Group A is near normal, Group B is much less normal, and Group C is severe. So you would see that the cardiac index drops from 2.4 to 1.3. Your SVR, systemic vascular resistance, increases, and your wedge also increases. If you look at the kidney, the green is your renal blood flow, and your yellow is your renal resistance. You would see that in patients with severe decompensated heart failure, the renal blood flow is much reduced compared to Group A, but the renal resistance to compensate is increased to maintain GFR. The left side of the concept map is labeled backward failure. It was in 2013 that a state-of-the-art paper was published in the Journal of American College of Cardiology. At that time, the group from Belgium, Hasselt University, headed by Verbeek, said, and I quote, "Current pathophysiological models of congestive heart failure unsatisfactorily explain the detrimental link between congestion and cardiorenal function. Abnormal congestion, meaning splanchnic, venous, and intestinal congestion, manifests in a substantial number of patients with advanced heart failure, but yet at that time, it was poorly understood." This is shown here. The circulation of the intestine behaves like the kidney's vasa recta. So the splanchnic arteries with the celiac, superior, and mesenteric arteries are connected together. If you have pre-arteriolar hypotension, the pre-capillary venules produce their elastic recoil, and they pull the blood, goes to the portal vein, and goes to the inferior vena cava. When this happens, the venous pooling is meant to increase the cardiac filling pressure at the expense of venous congestion. When this happens, there's so much venous pooling that the intra-abdominal pressure is also increased. The increase in intra-abdominal pressure affects GFR. The increase in intra-abdominal pressure increases venous pressure, and increase in venous pressure reduces renal blood flow. This was done in 1931, published in the Journal of Physiology, where the dogs had a heart-lung single kidney preparation. This is the venous pressure is increased, and this is when the arterial pressure is reduced. Looking at here, when the venous pressure of the single kidney is increased, there's a very dramatic drop in renal blood flow. There's a very good drop in urine flow. If the arterial pressure is decreased, there's also a reduction in blood flow. There's also a reduction in urine flow. But you would see the difference that the increase in venous pressure as a result of that experiment which is comparable to an increased intra-abdominal pressure that eventually increases the venous pressure, that the blood flow, when the venous pressure is increased, is much, much more. The drop in blood flow when the venous pressure is increased is much more pronounced than the drop in blood flow when the arterial pressure when the arterial pressure decreases, showing that the impact of an increased venous pressure on the blood flow appears to be more than the impact of the drop in arterial pressure. As a result of venous pooling, as a result of venous congestion, even if the blood pressure is the same, you would see that there's a systemic congestion, your CVP increases, and this is an adaptive, maybe maladaptive response to increase your cardiac filling, so you will have enough blood going to the heart, but at the expense of severe congestion. Systemic congestion will reflects an increase in intra-abdominal pressure, a drop in renal function, and this is where you have your cardiorenal failure. So I simplify this concept map where you have a decrease in cardiac output, you have a preload, which is systemic congestion, arterial underfilling, which is your afterload, and renal dysfunction. You would see that this is not a unidirectional map. If you have renal dysfunction, your arrow can go back to systemic congestion and it can further decrease your cardiac output. In the same way that when you have renal dysfunction, arterial underfilling can worsen it and it comes out in a very bad vicious cycle. The important message is kidney dysfunction is an important contributor to morbidity and mortality in those with symptomatic heart failure, particularly stages C and D, regardless of ejection fraction. So now concentrating ADHF, this is associated with poor clinical outcomes, no improvement over the past 20 years, but this was data in 2009. The 30-day readmission rate is more than 20%. The in-hospital mortality rate is about 5 to 6%. Combination of renal dysfunction with a creatinine of 2.5 milligrams per DL and hypotension upon admission in hospital has a mortality of more than 20%. The greatest predictors are troponin and creatinine. The 5-year cumulative probability of death is more than 60% in those with moderate renal dysfunction. It goes up to 80% for those with severe GFR of less than 30. The rate of hospitalization is 86%, and 55% had more than one rehospitalization per year. This is evident in all ages, regardless of NYHA class, duration of heart failure, hemoglobin, presence or absence of diabetes. In the PRIME study, which is the second prospective randomized study of ibupamine on mortality and efficacy, this is a subset of that study. This study was pulled out because of the high mortality with ibupamine, which is a derivative of dopamine. But you would see here very clearly the marked delineation of the curves that if you have a GFR of less than 44, your proportion of survival is definitely much lower than if you have a GFR of more than 76, or even if it's in the 60. I think what is striking is the relative risk of mortality. Shown in green is your GFR. This is a decreasing GFR, and the yellow is your LVF, left ventricular ejection fraction. Here you would see that if the GFR is greater than 76 or even 59 to 76, the relative risk of mortality is probably very close to one another. But when the GFR drops further up to less than 44, the risk of mortality rises by 3 times. On the other hand, the risk is much less with LVEF. This is seen in this 3-dimensional bar graph, whether it's LVEF or New York Heart Association classification. There is lower risk of mortality with decreasing left ventricular ejection fraction than when it is with GFR, even with New York Heart Classification or GFR. So from these 2 sets of slides, you can see that the GFR is pivotal in the survival of these patients over and above left ventricular ejection fraction and the New York Heart Association. They're additive, there's no question about that. But in terms of relative risk, it appears that GFR takes the lead. In the SOLVE study, studies of left ventricular dysfunction, prevention, and treatment trials, they stated that moderate renal insufficiency is independently associated with an increased risk for all-cause mortality and heart failure progression in patients with symptomatic and asymptomatic left ventricular systolic dysfunction. Rather than simply being a marker of disease severity, moderate renal insufficiency may be causally related to an increased risk for mortality and progression of heart failure. And I guess this is the sentiment of my cardiology friends who feel that the problem is really the kidney worsening our heart failure. So let's see. Having said that, and having said that the interaction between the kidney and the heart plays a pivotal role in therapy, let me now summarize for you the available therapies for this. Well, we have the inotropic support, dobutamine, milrinone, and I think there are now clinical trials like the Galactic trial for cardiac myosin activator. And we have this afterload, a lot of them. And the newest in the market is SGLT2, and device is left ventricular assist device. And the preload, this is where we come in, is dietary restriction, diuretics, tolvaptan, MRA, paracentesis, renal sympathetic nerve denervation, ultrafiltration. And in my attendance to the webinars, they say that SGLT2 also has an effect on preload and afterload. For the purpose of this conference, I will just talk about diuretics and ultrafiltration. I will not talk about afterload, inotropic. We have very good cardiologists who can handle that. I will concentrate on diuretics and ultrafiltration. Even with the diuretics, I will just enumerate the causes of diuretic resistance. Diuretic resistance is a clinical state in which the diuretic response is diminished or lost before the therapeutic goal of relief of edema has been reached. And I have 11 reasons here for the causes of diuretic resistance: inadequate dose of diuretic, non-adherence, high sodium intake, not taking the drug, pharmacokinetic factors, low absorption because of gut edema, impaired secretion of diuretic in the tubular lumen, CKD, use of non-steroidals, hypoalbuminemia, hypotension, nephrotic syndrome, anti-natriuretic drugs like non-steroidals, low renal blood flow, and this nephron remodeling means that prolonged use of loop diuretics causes hypertrophy and hyperplasia of the distal convoluted tubule, the connecting tubules, and the collecting ducts. Consequently, sodium reabsorption mediated by these segments of the nephron increases. And the last one is neurohormonal breaking. This is a very striking slide, but I like this. You can download this from Shituri, published in 2018, because these are the sites of diuretic resistance. You have the reduced GFR, the proximal tubular hyperfunction, distal tubular hypertrophy, distal nephron, and loop of Henle. It tells you the barriers to the reduced GFR, and it tells you the potential solutions. I will not go through each one of this because I'm sure you know this, but if you want this slide, you can download it. And it's a nice teaching slide because it tells you the site, it tells you the barriers, and it provides you with solutions. I mentioned earlier in McDonald's paper that diuretics had the worst outcome, but you see systemic congestion is a key target in the management of acute decompensated heart failure, and its relief is considered a treatment success. Sometimes you cannot, most of the time or all the time, you can't change the structure, but our aim is to make them feel better. Dry weight is very important at hospital discharge. Is considered a surrogate marker of successful treatment of acute decompensated heart failure with or without renal dysfunction. Use of diuretics is associated with worse outcome because of hypotension as a result of a decrease in filling pressure and decrease in intravascular volume. And as a result of that, we have encountered this condition, worsening renal function, where there's a rise in creatinine in the setting of ADHF. And the predisposing factors are if there's a pre-existing renal failure or because we decongested too much. And this is very common in real life. You get a referral of a patient in acute decompensated heart failure. The creatinine is increasing, and you would see that this patient has put out maybe 6 liters in 3 days. And that's a worsening renal function. But you also see is that patients diuresed, you thought they're dry, but if you look at their chest x-ray, they're still congested. Worsening renal function is something that we worry about. If it's transient, is it persistent? And the next paper tells us, is worsening renal function an ominous prognostic sign in patients with acute heart failure? This was published by Metra, the role of congestion and its interaction. About 600 patients studied in 2005 to 2009, mean follow-up of 1 year from the Hospital of Brescia. Predictors of death or transplant. If you have worsening renal function and congestion, that's really bad. If you have no worsening renal function, but you have congestion, may still not be that bad. It's not significant. If you have worsening renal function and no congestion, it's still not a predictor of death or transplant. So patients with no worsening renal function or no congestion tend to be younger. They are less likely to be male with no CAD, COPD, CKD, detectable serum troponin during hospitalization. They have higher BP, higher LVEF, higher hemoglobin, higher sodium. They have lower New York Heart Association classification, lower BUN, lower creatinine, more likely to receive an ACE or ARB at discharge, less likely to have an implantable defibrillator, received a lower average daily dose of furosemide, less likely to be treated with IV inotropes during hospitalization. So these are the good ones. And these authors say that worsening renal function alone, when detected using serum creatinine, is not an independent determinant of outcomes of patients with heart failure. It has an additive prognostic value when it occurs in patients with persistent signs of decongestion. So what then is the key to survival? There are 2 papers here from the University of Pennsylvania by Testani, where they look at the potential effects of aggressive decongestion. And one measure of aggressive decongestion is actually hemoconcentration. The black one is no hemoconcentration. The light one is hemoconcentration. And you would see that there's a drop in GFR in those with hemoconcentration. But you would see that the cumulative survival is better in those with hemoconcentration than in those without hemoconcentration. And if you look at their total net fluid loss, weight loss, those with hemoconcentration lost more weight and fluid, and the average daily fluid loss is more in those with decongestion, hemoconcentration. Early in brown, late admission to discharge, hemoconcentration, even up to discharge, they have hemoconcentration, meaning they're more decongested. But again, the survival probability is seen here when you have late hemoconcentration, meaning you have sustained decongestion. Your survival is much better than when you have only a partial or a transient hemoconcentration at the early part of your admission. In conclusion, hemoconcentration is significantly associated with measures of aggressive fluid removal and deterioration in renal function. Despite this relationship, hemoconcentration is associated with substantially improved survival. These observations raise the question whether aggressive decongestion, even in the setting of worsening renal function, can positively impact survival. Only hemoconcentration occurring late in hospitalization, meaning a sustained decongestion, was associated with improved survival. These results provide further support for the importance of achieving sustained decongestion during treatment of decompensated heart failure. So now let's go to real life. My first experience here was in June 2005, 59-year-old with dilated cardiomyopathy, acute MI, ARF on top, and I put him on hemodialysis. He had continuously had pulmonary edema, severe CAP, and I decided to put him on CAPD because you cannot keep him in the hospital for ages. So he has to have his ultrafiltration done outside. And he was kept dry for 6 to 7 months and with this UF, with a very simple regimen of CAPD. And he succumbed after 7 months due to pneumonia. And this is the daily ultrafiltration that I supervised him to do. In 2004, similar thing happened where outcomes of 19 patients with refractory congestive heart failure before and after ultrafiltration was done in Pittsburgh. And you would see here that the heart failure hospitalizations has dropped from 2.6 to 0.3. Days of hospitalization dropped from 41.8 to 2.4. And New York Heart Classification dropped from 4 to 3, or maybe 3 to 2. But the authors say that this is a very limited paper and we don't know the safety of ultrafiltration. That was in 2004. Then came this paper in 2012, a much quoted paper, CARES, where they looked at ultrafiltration and decompensated heart failure with cardiorenal, and they compared the effect of ultrafiltration with step pharmacologic therapy on renal function. The previous study was intermittent ultrafiltration. This one is continuous ultrafiltration. This was done between 2008, 2012, 22 sites in the United States, 94 patients, a total of 188, mean age of 68, mean EF of 33. These are the inclusion criteria. Primary endpoint is change in, this is a bivariate analysis, serum creatinine and change of weight, rate of clinical decongestion, and measures of global well-being and dyspnea. The assessment was done in 48, 72, and 96 hours and follow-up in 60 days. But look at the duration of UF 40 hours at 200 ml per hour, and that's amounting to close to 8,000 cc per day. The intravenous pharmacologic therapy was assessed at 92 hours, and they expect a urine volume of 3 to 5 liters per day. And this is the result. The ellipses represent 95% confidence limits. The one in red is ultrafiltration. The one in blue is pharmacologic therapy. You would see that the creatinine was much higher in the ultrafiltration group after 96 hours compared to the pharmacologic therapy. So they concluded that use of a stepped pharmacologic therapy was superior to a strategy of ultrafiltration for the preservation of renal function, with the amount of weight loss at 96 hours similar to the two approaches. Ultrafiltration was associated with higher rates of adverse events. I have very strong reservations about this paper. One, they were doing ultrafiltration so quickly, 200 ml per hour. And they were doing IV pharmacologic therapy, generating a urine of 3 to 5 liters. But in their paper, at the end of 60 days follow-up, their creatinine were the same. But what they have reported is the creatinine at 96 hours. And of course, since the ultrafiltration was done so aggressively, there was more hypotension and other complications due to that. From this, you can say that I'm very biased for ultrafiltration because ultrafiltration with peritoneal dialysis is continuously being done. This is a single center acute PD for 12 hours, 3 times a week, class 3 and 4, baseline GFR 19, improvement in 6 months, body weight dropped from 78 to 74. 25 patients with class 3 and 4 CKD, persistent fluid overload, at least 2 previous hospitalizations. Look at the main daily UF, only 679. And classification improved in 6 to 24 weeks, 84% reduction in the number of hospitalizations. And in 2014, refractory heart failure, GFR of 33, on PD for 16 months. First year, the ejection fraction improved from 38 to 42, 90% reduction in duration of heart failure related to hospitalization. So again, here's my real life experience. GB is 55 years old, male, businessman, very nice gentleman, a real gentleman, previous smoker, alcohol beverage drinker. He has congenital heart disease. And this is really magical. Congenitally corrected transposition of the great vessels 15 years ago. He was never cyanotic. From what I understood, the pulmonary artery that rose from the left ventricle also got into the right ventricle. So he was delivering oxygenated blood or something. But anyway, that was how he was labeled. 1 year history, bipedal edema, shortness of breath, easy fatigability. 1 week prior to admission, there was worsening of symptoms, grade 3, and ascites. His EF is 41%, and he has severe pulmonary hypertension, generalized hypokinesia, and depressed systolic function. This is his database. I think I saw him sometime in December 9, and you will see that before that, the creatinine was like so. The last time I saw him was July. The creatinine has gone up a little bit. High GFR, but there was worsening, but sustained, not too much. The hematocrit here, he is now having more hemoconcentration. Albumin has improved. Sodium has remained high compared to the 126. And this is the remarkable part. His NT-proBNP has gone down by more than 30%. In January, it was 660 picomoles, and in July, it's 312. His weight, my target weight for him was 76, but the last time he came was 81, so I changed his PD. But look at this. When he was at Heart Center, I kept him on Lasix drip, and then whenever I took him out of Lasix drip, you know, his weight would gain, he would gain weight. So Stacy, Dr. Stasio said, couldn't we do something else? I know he wanted me to do some UF. So that's what I did. I put him on PD, and you would see that this was his regimen: Samska, Lasix drip, Burenex, Entresto, and spironolactone. And when I saw him in July, he was only on Entresto. And I did a customized PD. We started with 6 exchanges per day, 4.25, 1.5. He wants a 30 minutes dwell because he can achieve his dry weight with 30 minutes dwell. I said, you can go 1 hour. He said, no, I like to do it 30 minutes because then I can do everything that I want. And then when it's time for me to do it, it's just more convenient for me. And I think he does it at night with the help of his wife. And this is what he has. And thanks, Cheryl Manalili. The red is the intake, the urine is the orange, and the PD output. And you would see that over time, up to now, his output, combining urine and PD, is more than the intake. keeping his weight low or controlled, but except for this last few days where he's been eating more. So I had to adjust his PD. Something striking. This is a normal EF. This is not his, but this is similar. That is a reduced ejection fraction. Short axis. And look at this. Look at the dilated chambers in the heart with the reduced ejection fraction. So in summary, what I have explained to you is that systemic congestion is a key target in the management of acute decompensated heart failure. And we should always remember that its relief is considered a treatment success. And we always aim for a class 4 going back to class 2, if at all. Are there biomarkers like NGAL? No, there are none. But you can use your NT-proBNP. If you look at the red and the yellow, this is NT-proBNP, where the reduction is less than 30%. This is with worsening renal function, and this is without. But here, you would see that the cumulative mortality rate is much less if your NT-proBNP reduction is more than 30%. This is the all-cause, this is the cumulative mortality, and this is the all-cause mortality, where you aim for an NT-proBNP with or without worsening renal function to be more than 30%. And our patient had more than 30%. So I do hope and I really pray that his PD would work because he's very active now, very intelligent, smart guy. And for these stages A to D, which is structural and increasing severity of heart failure to the point that you really cannot change what is in that heart from a stage of no structural heart to one, how can you change that? And this is where prevention, comorbidities should really be addressed because structural heart disease comes with the comorbidities like diabetes, smoking, obesity, hypertension. And this is proven by a study where they looked at the kidney biopsy in transplant candidates with kidney disease. Because in this center, they can do kidney and heart transplant. But if that's the case, they have to do a kidney biopsy first. So this is the biopsy of the heart, interstitial fibrosis, perivascular fibrosis, replacement fibrosis. And look at this. This is what they found on kidney biopsy. About a third are ischemic, a lot with diabetes. And this is primary GN, hypertensive atherosclerosis. So some here are actually the things that can be modified as early as stage A or stage B. But I think, again, this is the most important slide because no matter what we do, these measured factors explain less than half of the interregional variation in mortality, with unmeasured factors accounting for the bulk of the varying mortality risk. We happen to be in Southeast Asia, and you know there are differences in healthcare structure. There's delayed presentation to healthcare facilities, access to and delivery of healthcare, and the quality of healthcare. This is something that we all have, that we are sad about in Southeast Asia, and that the region, Southeast Asia, is more important than demographics, whether you're young, you're old, in predicting mortality among patients with reduced ejection fraction and preserved ejection fraction. So that is my story, the kidney in the failing heart. I have concentrated on acute decompensated heart failure. So I'd like to give hope. If we can do so, prevention is something that's very difficult, but can be done. And of course, our role as nephrologists, we have a lot to share. And I think we have cardiologists with very open mind who might like to try some of the modalities that I have explained. I'd like to thank Stacy, Dr. Ronaldo Stasio, who was the attending, and Des Lazaro, who helped me with echo. I pulled Donna De Leon from NKTI and took her PD team to initiate the dialysis on GB. Cheryl Manalili helped me with some slides and will be my co-author for the case report. Mick Agbayani lent me the data on the local data on heart failure. And of course, I'd like to thank GB for being very cooperative, trusting, and grateful. Thank you.
Okay, thank you very much, Dr. Mejia, for that very informative and comprehensive lecture. Please type in your questions into our Q&A box below so we can read your questions. You can also digitally raise your hands by clicking the button Raise Hand to be acknowledged. Dr. Mejia is now ready to entertain your questions. So, ma'am, we have one question from our Q&A box. Good PM. What is the threshold for hemo concentration that will provide decreased mortality? Thank you.
I don't know the answer to that. I think you have to look at trends. You know, this hemo concentration is not like polycythemia vera or erythrocytosis. This is really related to pulling out more fluid. So I really don't know the threshold. I think you have to go clinical on that.
Okay, ma'am. So next question. What do you think is a safe blood pressure to give Ibid diuretics in patients with heart failure, reduced ejection fraction in congestion, given the risk of decreased renal perfusion with low BP?
You know, most of the patients I handle with acute decompensated heart failure, they're, class 4, maybe stage D. They're usually on inotropes. And some compute for MAP. I'm very simple. I just say, just give me a blood pressure of 110, then my diuretics will work. But diuretics won't work if your systolic is 90 or even 80. But ultrafiltration can work, even with low BP, for as long as you do it very, very gently.
Okay.
So remember, your diuretics, like your furosemide, you need perfusion to let it go to the tubules. Mm-hmm. So if you don't have any stream to carry it through, it won't react. So I need a relatively good BP, maybe 100, 110 to give your IV. Because if it's lower than that, it won't work. And nag-uumpisa ka pa lang, bumagsak na ng konti, wala pang ihi, sasabihin ng cardiologist or ng CFOD, I stopped it because the blood pressure dropped. If you just started it, wala pang vasodilatation yan, I don't think it's from the furosemide.
Okay, ma'am. Dr. Raline Gomez is raising her hands. Ma'am, you can raise your question already.
Hi, ma'am. Thank you, as always. Your lecture is really explaining a lot of things, and your unique way of approach to this patient can really help a lot of practitioners on how to approach this very problematic ADHF or decompensated heart failure. So you showed, ma'am, that very small increases in creatinine or decreasing EGFR can really be detrimental and leads to worsening renal function. So in this very unstable patients, especially when they are admitted for heart failure, what would be your most used way or manner of calculating the GFR in terms of monitoring their worsening renal function? You said biomarkers are not very helpful, but in terms of, for example, very small changes in creatinine will impact on GFR. So what will you be using in terms of the calculators?
Well, first of all, like at Heart Center, the range for creatinine, let's say, is 0.08 to 0.08, 0.06, no, 0.08 to maybe 1. Sometimes the creatinine, the patient kasi cachectic, walang muscle mass 0.06. And then the creatinine goes up to 0.09. It's still within normal range. But if you compute the GFR, that GFR has already dropped. And I just use the CKD epi. I don't even have an app. I just use my, this thing that you move back and forth.
Okay.
The one that I got from ASN, which is very accurate though. So I compute the GFR and I really am attentive to it and say that, look, we may not have to be too rapid in diuresing these patients. And worsening renal function, as I have said, may not always be troublesome. It's troublesome for us because, it goes up. But if it's transient, it may not mean bad, poor survival. But if it's persistent, then that's a different story. So I'm very simple. I just make sure that if I always compute for the GFR every time that the creatinine is taken, even if it's within the normal range. An increase from 0.06 to 1 is within normal, but that GFR is no longer the same. Yeah, that's how I do it. I don't, the biomarkers, even in the last lecture on AKI, you sort of have concerns about biomarkers. And biomarkers, you really have to do them serially. You cannot just use one biomarker to say that's it. You still have to do it serially. And biomarkers are good if your population is homogeneous. But if your population is septic, there are so many, it's a heterogeneous population. You have so many factors involved. And the studies on the one that I know on biomarkers, they're nice to do it if you have a homogeneous population and you just don't do them once. You do them serially.
And maybe I just like to comment also on the hemo concentration, because really now, in terms of the important hypoxic inhibitor factor, which is actually the one that is positive in terms of maintaining oxygen tension and maybe the downstream effect of improving oxygen delivery, is the mechanism for the important effect of hemoconcentration. So I think the mechanism of preload and afterload unloading, specifically of the SGLT2 inhibitors, probably also is adding to that important benefit, which is hemoconcentration.
Well, the hemoconcentration paper I presented are acute studies. When they decongest, the hematocrit goes up. So it's actually a marker of your degree of decongestion. So if your patient is euvolemic, maybe that hematocrit will come down and not be as high as that. You also have to remember that many of our heart failure patients are anemic. Iba nga, they're on EPO before, I don't know now. But
Yes.
their hematocrits are low. So this hemoconcentration that I reported is actually based on acute studies, and you will see that the follow-up is 60 days. The assessment is only 72 hours or 96 hours. It may not be the same as the hemoconcentration that we would like to see in patients requiring more oxygen delivery. And in that particular study, how much hemoconcentration was there, Lynn, in the papers that you reviewed?
Actually, it's really more of those who are living in high altitude that they compared that, their kidney functions becomes better, their EPO were lesser in requirement because of the stimulation of the heat factor in these patients. So that's what they are trying to invoke. So,
Yeah, I think, there's a point to that, but I think the way I describe hemoconcentration, it's more of as a consequence of decongestive therapy. And it's really an acute phase. Maybe what they're describing in the papers in the high altitude are more of the chronic state.
Okay, thank you, ma'am.
Hi, ma'am. I'll just pitch in for CJ. I think the computer went off.
Sure.
The next question is from Dr. Celia Uy, do we have local data comparing prevalence and outcomes of heart failure patients on chronic HD, CAPD, and post-KP?
You know, I wish I had more referrals from cardiology or for both of us to be really accumulating these cases because it's something that we were thinking in Heart Center, and I in fact told Donna that maybe we should set it up for heart failure. I don't have too many cases yet. I have a few, and sometimes the cases we start don't survive long enough. I guess it depends on where, but GB is a very encouraging case. Maybe we need to do this. I don't have any local data. I have personal data, but not enough.
Okay, we have a question from Dr. Serna. Do you have any experience on using body composition monitoring in setting dry weight for patients with heart failure on intermittent hemodialysis?
No, we haven't done that. In fact, I don't do that much, even in the outpatient dialysis. I think it's a nice modality to see. You have to just bring them there. I like to use my clinical eye in deciding on the dry weight. I've tried it several times in my OPD, and my estimated dry weight is very similar to the BMI, and they don't have to pay me extra 300 or 600 to compute the dry weight. So maybe it has its use. It has to be protocolized though.
There is a question, ma'am, on two particular drugs, neprilysin inhibitors and tolvaptan. What is your experience in patients with low GFR?
Okay. The other one is ARNI, right?
Yes, ma'am.
Cubitril and with valsartan. With tolvaptan, I think the experience is more for an acute, symptom relief. I think that's what I learned from tolvaptan from Everest. And a lot of cardiologists are giving it. And I got involved in giving it because we want to send the patient home and not be on Lasix drip. Okay, so that's one way of doing it, although I never got the chance to follow it up. There are patients too who don't respond too well on tolvaptan no matter what you do. But I think it can increase your diuresis. You have to monitor your sodium. We had the case on tolvaptan with a sodium of 170 with neurologic dysfunction and was given tolvaptan as outpatient. I'm not too much into it, honestly, but I consider it if I have to put this patient, if I have to send this patient home and not be on Lasix drip. The sacubitril valsartan, I think it's creating wonders. We have just titrated doses based on more on blood pressure. Yeah. And I think I had one case where there was an acute kidney injury from that drug, very classic chronology. But that was I only had 2 cases, all the rest are on that. And I have patients on ARNI with a creatinine, with a GFR as low as 20, but the dose is not full dose. And then usually what I do with my cardiologist, we titrate the dose to keep the BP higher. Because if the BP drops too low, then the creatinine would also go up because of hyperperfusion. I have given it to patients with GFR maybe in the 30s, but very careful.
Okay. So we have just a few more questions. So there's a question, I think it's moving. Among CKD patients, I understand that we have a level of hemoglobin that we try to target because of risk of thrombosis if we have higher levels. How could we balance the benefit of hemoconcentration with the risk of thrombosis among CKD patients with heart failure?
Well, that's already the far advanced cardiorenal. Okay. And usually under those circumstances, I can just imagine your patient has low BP because of severe heart failure. Your patient has congestion. Your patient has ascites. And I don't know how much diuresis you can achieve on these people because the blood pressure in the first place is low. I put them on Lasix drip while they're in the hospital, but they're always on inotropes to keep the BP. But I guess, yeah, I guess these are, the problem with these patients is we always want to send them home, but the medicines that we're giving, we're keeping them there because of the Lasix drip, the IV Lasix, or even the inotropes. This would be the ideal population we can study for ultrafiltration. And I have no experience. I don't have any experience yet or haven't seen how hemoconcentrated they will be because they're really hemodiluted because of their heart failure. Yeah.
So we have a question from Dr. Benji Balmores. For those patients with heart failure not responding with intermittent diuretic, is it still okay to try them on continuous diuretic infusion?
Yes, I think there's so many debates on IV intermittent with continuous, and my basis for leaning towards continuous is what I have learned from Burton Rose, no? That S curve, the logarithm for the excretion of furosemide. Yes, I shift from intermittent IV to Lasix drip.
Okay, ma'am, I know it's been quite a long discussion and very fruitful, but I'll just ask one last question from Dr. Danilan.
Okay.
Does using iso-ultrafiltration in patients with normal renal function may be useful for congested patients since it removes isotonic fluid? Would you recommend this therapy in certain cases?
Definitely. In fact, GB has well, his creatinine went up a little bit, but overall, his kidney function is still not that bad. And I put him on peritoneal dialysis, basically for UF. And my diagnosis is ultrafiltration for acute decompensated heart failure. I didn't put stage 2 or 3 of CKD. No, you can. Yun nga lang, it's actually setting up. And that's what I hope Donna will help me set it up para madali.
So, ma'am,
it's not too expensive anymore.
Ma'am, thank you so much for answering the questions and for the wonderful discussion. And I think everyone learned a lot from this webinar. So thank you again, Dr. Mejia.
Okay, good night.
Good night. So to all of participants, thank you again for participating. I'd like to thank also Dr. Lynn Gomez for the lecture earlier and also our moderator, Dr. Guatis. Next week, we have Professor Mac Debro from Belgium, who will be giving a webinar on chronic interstitial nephritis in agricultural communities. So I hope that you could join us again next week. So stay safe, everyone, and thank you for joining our webinar. Thank you, ma'am.
Thank you.